Sure, Miguel. So one of the things in general, when I see an elderly person with abdominal pain, that makes me a little uncomfortable. Abdominal pain in an elderly person, the differential is kind of very wide. So we're starting off with a 70-year-old man with abdominal pain. It's been there for 2 days. We have some location. Chills is one of those things that we have highlighted, but I'm still not sure what to do with that complaint after 25 years of practice. Everyone seems to have chills, so I'll just kind of tuck that away. Confusion, absolutely concerning. The differential diagnosis for just confusion is broad, but in this setting, someone with abdominal pain and maybe, or at least some subjective fevers, starting to point me towards maybe an infectious etiology. Vomiting in the setting of a gastrointestinal symptom, I'm not exactly sure what to do with that. Not eating and still vomiting, concerning. I think the next line is very telling actually here for me. The patient has a history of hypertension controlled with hydrochlorothiazide. So they're kind of laying out he has hypertension, and when we skip down to looking at the blood pressure, 100/60, his mean arterial pressure there is normal. But I would say, where my residents would say, that's a soft blood pressure. There's something about that blood pressure if this person was well and went to your office and they were on an antihypertensive like hydrochlorothiazide and their blood pressure was 100/60, you might be thinking about taking them off of that medicine, right? So to me, although not low technically, is a soft number and it's definitely pertinent here. This is building evidence for me that this is a sick patient. There's tenderness over the liver, there's no guarding, so it's not a surgical abdomen. And then of the labs here, obviously the amylase is of note. There's an elevated white blood cell count, and there's a shift to the left with the bandemia. Although those are not specific findings or values for any one particular diagnosis, they're adding weight to what we're looking at here as a sick elderly man with abdominal pain. All of these things are additive and contributing to getting to the correct answer. We're also told about some other labs, BUN and creatinine. There's an ultrasound given, there's multiple stones. So now I'm thinking, okay, does this person have cholecystitis? I've seen a lot of patients with cholecystitis and they generally don't look this sick. And so putting it all together, whether the 9 millimeters is wide for a common bile duct or not, I think we're looking at a very, very kind of seriously ill man that has pathology in the right upper quadrant, right? The physical exam is not telling a lie. One of the things that I do clinically, and when I talk to my students and residents, is that if you have a pertinent physical finding, positive physical finding, it's relevant. I like all of your choices. I'm curious to see what the option set is, and then we probably need to make a few more choices once we see that, I suspect.
Thank you, Dr. Rebecki. I guess one thing that I might add is I worry about the confusion. In my world of geriatrics, an elder with confusion can be an equivocating sign for a lot of bad things, even in the absence of fever, even in the absence of renal dysfunction, as we see here, or worsening LFTs. I think, again, from a construct standpoint, the item writer probably thought, I might be able to throw someone off a little bit off the trail here if I just make the renal function normal and the LFTs normal, as a means to sort of discriminate from the higher performer versus the lower performer on an exam, let's say. So let's take a look at the option set, and we'll have our panel weigh in on what they think the answer is. So which of the following is the most likely diagnosis? A, acute cholecystitis, B, acute pancreatitis, C, cholangitis, D, hepatitis, or E, liver abscess. And you may enter your choices now. All right, looks like we have everybody's answers in. Dr. Rebecki, I'll have you take it away.
Yeah, thanks, Miguel. So I'm going to come down, at least my thinking, patients I've seen or ascending cholangitis are going to be sicker, number one. And number two, I know a little bit about ultrasound and that Somebody who has cholecystitis, acute cholecystitis, is not only going to have stones, they're going to have a thickened gallbladder wall and fluid around their gallbladder wall, which we don't see here. We do see a wide common bile duct and all of the other clinical things that you all kind of pointed out. So I would come down on cholangitis with this question. Miguel, you want to add anything to that?
Yeah, and in this, as an internist, I like to think about these things on two different levels. One is what's being damaged here based on the labs. Is it duct cells? Is it hepatocytes? Is it pancreatic tissue? Or more than one of those things? And then work backwards and say, well, what can cause that? And in the case of cholangitis, it's always going to be obstruction or poor flow, right? Let us reveal the correct answer. So the correct answer is cholangitis. I'd be interested to hear from our panel about any thoughts now that you've seen the option set and the answer. And I'd be kind of curious what you might do next.
Yeah, I was just going to say that I agreed with a lot of the explanation that was already mentioned. And usually when looking through those answer choices, you can sort of eliminate options based on things that you don't see in the answer choices. So for example, like the acute hepatitis, I would have crossed that off right away once I saw that the liver enzymes were normal. And then I thought that the point about the ultrasound findings, how with cholecystitis, you'd really see that inflammation of the gallbladder wall. That would be that, and the patient not being so sick would really sort of clue me into cholangitis over cholecystitis, which was also mentioned.
Any thoughts on what you do next, anyone?
So we basically nailed down the diagnosis pretty solidly. So next step is definitely to treat and stabilize. So we need some like pretty broad spectrum antibiotics, gram-negative rods, anaerobic organisms for the, the ascending infections. I think he's already gotten fluids, so that's good. Oh, he's already had antibiotics. Okay. Well, maybe you could do like a CT scan with contrast if you wanted to assess for like the extent of the infection or other like complications. But he probably needs to be like admitted to the ICU.
I definitely agree with that. In terms of imaging modalities, from what I recall, I believe ERCP might be the first thing you do if he's stable enough. But I agree with you, Brooks. I might image this guy just knowing that he has hypertension as a diagnosis and looks like he's probably not taking his meds for 2 days. And despite that, he's hypotensive. So this might be someone you would not necessarily want to be putting under conscious sedation right away. So maybe you will go straight to imaging, maybe MRCP or CT as well. Other thoughts from the panel about what you do next?
I'd probably also want to get blood cultures so that we don't have to keep doing broad spectrum. We can narrow it a little bit. That's the stewardship, antibiotic stewardship part of me speaking.
I love it. And no doubt doing a definitive procedure and then narrowing the antibiotics is definitely the first step. And you think about when we didn't have ERCP even, this was something you did operatively. You would open up the belly and take the stones out, and that had about a 50% mortality.
Let me jump in here just because a couple of things kind of came across my mind. Mm-hmm. So you guys nailed this and did a great job in kind of your reasoning, which is, like Miguel said in the beginning of this, is like to kind of treat these like a gentle rounding. One of the things that I heard a couple times during this, and maybe I'll ask Miguel to comment, is that you might think of this stem, this question, this scenario, leading to several different types of questions, right? We asked here, what's the most likely diagnosis? You might think, what's the next best diagnostic test? Because you guys talked about that. What's the most appropriate treatment option? Who are you going to consult with? I mean, there's lots of different questions that could be kind of brothers or sisters of this item.
And a lot of times when a question like this is written, our test committees will be around a table and they'll read it out loud and they'll make tweaks to the content, make sure it's up to date, make sure it's accurate. And then they'll decide, well, what level of student should be taking this question? Would this be a third-year medical student, a senior medical student, or even someone in residency? And those are the types of things they would be deciding. This question would be fair game, I think, for an intern or a resident. And so I would say, kudos to our panel. You you nailed this one, and you haven't graduated yet, I think. So well done.
I think it was important to recognize that all the information that you needed was in the answer, or in the STEM. As you mentioned, like differentiating between cholecystitis and cholangitis, a lot of that was with the ultrasound and like the thickness, how it's not mentioned in the question STEM. So therefore, it's not thickened, and you can assume it's not thickened. So
Yeah.
you can steer more towards cholangitis.
Yeah, it's a great point, Gene. And I know that Miguel mentioned the word distractor often when we were talking about this item, and there are distractors in every item, but distractors you should not equate those to things that are going to confuse you. The information that's presented here, there's no tricks in these questions. It's truthful. It's like, oh, he doesn't have right upper quadrant pain when it says that he does. So yeah, that's a good takeaway. And when you're looking at questions, NBME questions, others, that you should assume that what you're reading is truthful and that they're not trying to trick you.
I'll say one more thing that has helped me, especially if with that common situation of narrowing it down to two that you're sitting there going back and forth on. Like for example, if maybe one of the choices here had said choledocholithiasis, and you're trying to decide which one are they going for. One of the things that I do is look at what information did they give me and what information did they not give me. And if this was, take this into choice between the two that I'm considering with this one, if they were really trying to test me on this concept, what is the important information that they would always make sure to give me? Or what would be the information in a clinical situation that we would be straight lining for? And if that information isn't given, or if some of it isn't given, then trying to get into the mind of the question writer, they may be trying to go for the other one.